Okay, this is an educational video on a pathology that's really common in climbers that have been climbing a long time. So if you're someone that has been climbing for decades, and you know people that have been climbing for decades, all of the finger joints are going to be a little bit bigger and a little bit bulkier and maybe have a modified range of motion as a consequence of mechanical stress on the fingers that is brought on by climbing and training for climbing and finger training and lifting, etc. These are the adaptations that we can consider kind of inevitable at some point in a climber's career. However, when they become symptomatic, they become pathologic. We want to manage the pathology and the symptoms, not really the picture. In some instances, and I'll show you an example of one that maybe we need to actually treat the structure if there's bony outgrowths that become displaced from the bone, which can be a source of irritation. But most of the time, these are simply pathologic and symptomatic. We want to manage the symptoms as best we can. So osteoarthritis, there is a positive correlation with climbing years. So people that have been climbing for a long time, grabbing small holds, twisting small holds, doing lots of training volume, there's a good relationship there with having osteoarthritic changes. Intensity of climbing, as the holds get smaller, the moves get more technical, there's more downward pressure, more twisting, there's just more stress to the joint, the PIP joint and the DIP joint. It's not that common to have arthritic changes to the MCP joint, even though that's possible. The majority of these are going to be in the PIP and the DIP joint. Changes in osteoarthritic changes refer to changes to the cartilage, which is inside the joint, as well as the joint capsule and the ligamentous attachments on the sides. So the picture that I'll show you is an example here. This is an example of a DIP joint. So this is a distal interphalangeal joint. As it was this finger, let's say, the tip of the finger is to the right, and then the middle phalanx is to the left. So we're really looking right across the distal interphalangeal joint. You can see here, here's the distal phalanx, and then here's the middle phalanx. And you can tell from this picture, if I zoom in, there's a little bit of a bony outgrowth, and there's also a little bit of a calcification right there. So it's very common for athletes to have repetitive stress and micro injuries to ligaments or tendons or the joint capsule that will essentially calcify. So it's a micro injury that will turn into granulation tissue, which is trying to heal, but that can also turn into a calcification. So it can turn into a bony outgrowth. In this case, if this fragment was displaced, there is some indication to go in there surgically and excise those, so remove those bone spurs down. That's not as common as you might think if you have osteoarthritic changes. But again, that's another option that we have. So this is a tissue here coming over the top. And you can see that the bony outgrowth is close to the joint. Think about this as like there being rock, and you're constantly pulling a tendon or a ligament over the edge of a rock, and as a consequence it gets bigger and bulkier and stronger, but then it also creates friction and irritation at the undersurface of the tissue. So if these are symptomatic with full crimping, with grabbing bars, etc., there needs to be a period of deloading where we're not loading the fingers on the climbing wall, we're rehabilitating the fingers, letting the things calm down, but it tends to be a little bit longer of a process. For people that have arthritic changes to the joint that all of a sudden become painful, either going on a climbing trip or introducing a new climbing cycle or training new training stuff, and we get symptomatic, we want to manage the symptoms, and we want to do so in, here's a couple options that we can use. So movement therapy. Movement is good for the joint, but climbing movement isn't all the same. A lot of times we have to get away from the climbing wall or significantly reduce the climbing volume to get motion to the joint, get some form of intensity to the joint, but we want to make it as easy to understand as possible by using a fingerboard, by using no lift, no hang tools, by using other types of implement to make sure we're not getting that same repetitive stress. Anti-inflammatories are commonly a first line of defense. You can take an oral anti-inflammatory like ibuprofen, or you can do a topical anti-inflammatory, use Pensade or Voltaren gel to try and get the inflammation on the inside calmed down. The topicals tend to be a little bit less effective at reducing the pressure inside the joint, and in that case we need to do intra-articular injections. Okay? Another common management strategy is icing. So we can ice the finger, or we can do contrast bathing to the finger. Icing is going to be a few minutes of getting your finger numb, a few minutes of thawing, a few minutes of getting it numb, a few minutes of thawing. The contrast bathing is cold, hot, cold, hot. The validation or the justification for those is to try and get more blood flow to and from the finger without mechanical load to create a metabolic stress and to also hopefully get a flushing effect of the inflammatory material away from the joint to help the swelling calm down. If the joint's quite swollen and quite sore, those tend to be less effective. A steroid injection tends to be the preferred option. If we get one at the DIP joint though, a steroid injection is not as feasible because the space is so small, it's really hard for a physician to get a needle in there to actually get an anti-inflammatory benefit to the joint itself. Other options are PRP injections. Those tend to be after trying conservative therapy, trying steroid injections, not responsive, then doing a PRP injection might make sense. Stem cell injections are also another option, but those are still in the exploratory phase, most people would consider. And I would say most people don't need those things. The reason that people tend to do those things is they become very impatient. So the osteoarthritic changes have happened over long periods of time. They're not going to go away instantly. So it typically takes a couple months to get an arthritic joint that also has some capsulitis in it to calm down without doing steroid injections. So I typically prefer people book an 8-week or a 12-week phase to make sure we can unload the joint, make sure we can reduce the inflammation in whichever way makes sense to them, or try a couple different things, and then we need to reload the joint, then we need to progressively overload the joint, and then we need to get you back to full climbing, but it's definitely going to take a little bit of patience on your part.